The endocrine system. The endocrine system is primarily controlled by the hypothalamus and the pituitary gland. The hypothalamus sends hormones to the anterior and posterior of the pituitary gland. At the posterior of the pituitary gland, we have oxytocin and antidiuretic hormone. At the anterior of the pituitary gland, hormones are sent that will target other glands. So we'll talk about some of these glands. For example, in the neck, there's the thyroid gland. The thyroid gland has two lobes with an isthmus or bridge that connects both lobes, and the thyroid helps to regulate our metabolic processes. While at the back of the thyroid are the parathyroid glands. These are four tiny glands that assist us with regulation of calcium in the blood. As we move further down in the body, there's a thymus in the chest. The thymus gland is known to be involved with synthesis of T lymphocytes, which we use for, mounting an immune response. As we move lower down, the kidneys, we have two kidneys, and atop each kidney are the adrenal glands. The adrenal glands have an area that's called the adrenal medulla, as well as an adrenal cortex. The adrenal medulla secretes our catecholamines, otherwise known as adrenaline and noradrenaline, hence adrenal glands. And of course, there's the adrenal cortex, where there is the secretion of corticosteroids. We have other glands such as the testes and ovaries, which of course secrete the hormones that influence our secondary sex characteristics. When we are studying physiological adaptation to disorders of the endocrine system, we want to remember that most times either the gland is over secreting, so we'll have a hyper state, or the gland may be under secreting, so we'll have a hypo state. For example, if the thyroid is under secreting, where the patient will have hypothyroidism, then to fix that, we would counter with giving the patient Synthroid, which is synthetic thyroid hormone. Whereas if the thyroid is over functioning, we use medications I like to call it zap the thyroid, or we cut out portions of the gland. So always remember that it's either a hyper or hypo state, and always remember how we treat each state, regardless of the gland. So let's start with the thyroid gland. We're going to talk about thyroid gland disorders. When there's a decrease in the synthesis of thyroid hormone, we say patients have hypothyroidism. When we see hypothyroidism in children, we refer to this as cretinism, while in an adult, we call it myxedema. So hypothyroidism is usually present, or we check for it in all children who are in the lower growth percentile, because we know that the thyroid hormone helps to assist with metabolic processes and growth and development. So all children in the lower growth weight percentile are usually screened for hypothyroidism in this country. Your assessment findings for someone who has hypothyroid will include lethargy. They'll have intolerance to cold. Everything is slowing down. Remember, metabolic processes. So they'll have bradycardia. They'll have dry hair, coarse skin, coarse hair. They'll even be constipated because peristalsis is slowed. Now, diagnostic tests would reveal lower amounts of thyroid hormone. For example, you'd see decreased T3 and T4 levels, as well as they could do radioactive iodine uptake testing as well to see areas of the thyroid that might give a certain distribution pattern. Now, what are our interventions? Remember, this is a hypo state, so the thyroid is under functioning. So what should come to mind is that we provide thyroid hormone to the patient. If the patient is severely affected, we provide IV thyroid hormone. If not, for maintenance and management, chronic care, we would use thyroid hormone. Now, for all the assessment findings I described, our nursing interventions would be to meet the patient's needs there. So if the patient had dry skin and coarse hair, we would moisturize the skin. If the patient is intolerant to cold, we would try to make their environment a little bit more warm. We would regulate. With hypothyroidism, once we start giving clients the Synthroid, they can run the risk of becoming hyperthyroid. And so we tend to give Synthroid early in the morning, like 6 a.m. med pass, because it is known to cause insomnia, because it increases the metabolic rate. We also do or monitor intake and output as well as daily weights, because we want to see if our client with hypothyroid, usually clients gain weight. So if we're giving Synthroid, we're now monitoring them to see if their weight is now getting closer to balance or what their norm is. Because of course, we're always keeping the body in homeostasis. So you always want to observe for certain signs. There's something called thyrotoxicosis, where the client becomes toxic on the Synthroid or thyroid hormone. And so we would monitor for things like tachycardia if they're becoming toxic. And then, of course, we monitor for signs of myxedemic coma, where they get really sick because the hormone is low, and we would give IV thyroid hormone. Hyperthyroidism results in an increase in synthesis of thyroid hormone. In this case, the client will show hyperthyroid symptoms, such as tachycardia. They'll have fine, smooth hair. Their skin will be more pliable. They'll have intolerance to heat, for example, or have difficulty regulating heat and cold. They'll have palpitations of the heart. They'll have tachycardia. Because when you think of hyperthyroidism, think of all the metabolic processes speeding up. So rather than gaining weight, with hyperthyroidism, clients lose weight. There's weight loss, they have an increased appetite, and even peristalsis is increased, and so they'll have diarrhea, because nothing is able to stay. Everything is moving very fast. Even their mentation, they're more irritable. Of course, diagnosis will see T3 and T4 levels elevated. So for all the assessment findings described, this is where nursing interventions would be. So if the client is extremely irritable and restless, we want to provide them rest. We want to provide a cool environment if they're hot. We want to provide a high caloric, high protein diet, because we're trying to help them gain weight or balance or maintain their weight, as well as we would still conduct daily weights to monitor. We can also observe the client with hyperthyroidism for signs of hypothyroidism. Why? Once we intervene, we're going to use medications such as propylthiouracil or tapazole to reduce the thyroid synthesis of thyroid hormone. When we do that, we can run the risk of making the client have hypothyroidism, because we're reducing the function of the thyroid gland. So we still have to monitor for those signs, like the bradycardia and the thickness of the skin and gaining weight. So this is why daily weights, for example, is part of the nursing interventions for the client with hyperthyroidism. If the hyperthyroidism is not amenable to medication or pharmacotherapy, then we have to do surgery. And so the surgery is called a thyroidectomy. We no longer cut out most of the thyroid. Usually a piece of a lobe is removed, because we have to be careful, the surgeons have to be careful about removing the parathyroid glands, because we cannot live without the parathyroid glands. So once they have exceeded anti-thyroid drugs such as the propylthiouracil or the tapazole or Lugol solution, we then have to think of pre-op and post-op measures for the nurse. So pre-operatively, we ensure that the anti-thyroid meds are given. We also, it's routine pre-op care. So we give those anti-thyroid meds. And then post-operatively, now, whenever there is neck surgery, the thyroid is in the neck. Whenever there is neck surgery, you have certain things at the bedside, like a tracheostomy set at the bedside. You must have suction and oxygen at the bedside, even if your client doesn't have any respiratory distress, but you have it as a prophylactic measure. You also would be monitoring for bleeding from the neck. You would be keeping the client in a low fall position and checking for bleeding, instructing the client to rest their voice as well.